Dear colleague, welcome to this presentation of DBS for psychiatric disorders, an introduction for psychiatrists, Part 1, What is DBS and how is it done? My name is Patrick Blomstedt and I'm professor in stereotactic functional neurosurgery, but I'm giving this presentation on behalf of the Task Force for Neurosurgery for Psychiatric Disorders in the World Society for Stereotactic and Functional Neurosurgery. And the selected experts in the faculty consist of psychiatrists, neurologists, and neurosurgeons. Our intention is to provide a brief overview of DBS for psychiatric disorders, focusing on what might be of interest for psychiatrists. You can find this lecture and about 250 others at the Stereotactic Academy at stereotactic.org, where we have gathered experts within the field of deep brain stimulation from the whole world. This lecture is also the introductory lecture of a course for psychiatrists given in collaboration with a number of organizations. We will later also provide a CME accredited version of this course at another website, stereotactic.se. To get access, you need to register, but all content is completely free for healthcare personnel. The course is intended for psychiatrists who would like to have a general introduction to the field of psychiatric neurosurgery. The course consists of 5 lectures. In the first part of the current lecture, we'll look at what DBS is and how it is done. In the second and third part, we will look at the long and fascinating history of psychiatric neurosurgery and how this has led to where we are today. And in the fourth part, we will provide an overview of modern DBS for psychiatric conditions. We will here look briefly at a number of experimental procedures, but since DBS is only established for one psychiatric disorder, OCD, we will then discuss this in more detail in the fifth and concluding part. These lectures might provide more information than you really need, and if you find this to be the case, just focus on what you deem to be of practical importance and listen to the other details in order to get a deeper understanding of the field. For those of you who on the contrary find the course content too meager, we are also suggesting other lectures and scientific papers for further reading. So let's start by looking at how DBS is done and how it works. Deep brain stimulation is a stereotactic neurosurgical procedure, and stereotaxy is basically space geometry. It is a method to identify any point in the brain with the mathematical coordinates of a three-dimensional coordinate system. It is also the name of the technique which we are using in order to reach the deep structures of the brain based on these coordinates. We will in the next lectures go through the historical development in detail, but basically stereotactic functional neurosurgery was introduced in 1947 with the specific intent of reducing the side effects of lobotomy. Typically, a radiofrequency electrode was introduced into the structure of interest in the brain, and this was heated until it coagulated the brain substance around it, thus producing a lesion. Stereotactic procedures were first used for psychiatric disorders, but it never attained any widespread popularity, but it came to revolutionize the treatment of movement disorders. This was the first effective treatment for Parkinson's disease, and soon thousands of patients had been operated. In the modern era, lesions have been mainly replaced with DBS. Electrodes are implanted into the deep structures of the brain and connected to a neuropacemaker to modulate pathological brain signals. The great advantage of DBS compared to lesions is that stimulation is reversible and that you can modify the stimulation after surgery with regards to effects and side effects. The introduction of DBS has been a success story, and we've seen a dramatic expansion of indications, targets and techniques, with more than 230 patients operated worldwide, and with more than 15,000 scientific papers on PubMed. And the success of DBS for movement disorders have sparked an interest also in the potential of DBS for various psychiatric conditions. Let us now continue with how DBS is done. There are a number of different DBS systems on the market, but they all consist of the same basic components. We have an electrode, also known as a lead, of around 1.2 millimeter in diameter that is implanted into the brain. This is anchored to the skull using a small anchoring device and then attached with an extension cable to an implantable pulse generator or IPG, popularly known as a neuropacemaker. We have also the external programming device and the patient's own control for communication with the IPG. When we want to insert an electrode into a certain point in the brain from outside the skull, we need to know where the target is in relation to a point of reference outside the skull. For this reason, we use a stereotactic frame or a frameless system. Thus, we attach a frame to the head to work as a reference point, and we then perform an MRI, CT or X-ray to simultaneously visualize the frame and the intracranial structures. However, in reality, we are not looking directly at the position of the frame. Instead, we attach an indicator box to the frame, from which we can calculate the location of the frame based on the markers in the indicator box, so-called fiducials. These fiducials are creating a three-dimensional Cartesian coordinate system encompassing the whole brain. We can now look at a map of the brain, also known as an atlas. And here we can identify the structure of interest, that is our target. Unfortunately, the map is not always in accordance with the individual patient's own anatomy. For that reason, most centers will today not trust the map, but will instead look directly at the patient's MRI in order to identify the structure of interest based on the patient's own anatomy. Of course, we do not always implant the electrodes in the same brain structures. We are targeting different structures, so-called targets, depending on the patient's symptoms. Here we see the published targets for depression, OCD and Tourette syndrome. Most of these are experimental, but here we have the targets used for OCD in clinical practice. After having identified our target, the next step is to find a suitable entry point and trajectory through the brain, avoiding blood vessels and sulci. When we have decided the target point and the entry point for the electrode, then we can calculate the coordinates for these points, and this is today done with the help of advanced navigation systems. In the OR, we will add the stereotactic arc to the frame. If we put this in its neutral position on the frame, then it would coincide with the origin, that is, with the center of the stereotactic system. However, we don't want to reach this, but our target structure for DBS. So we set the coordinates for this target so that the center of the arc becomes displaced and is now coinciding with our intended target. We see the same in this video, how the arc is recentered as to coincide with the target. The angles can then be set to the chosen point of entry. An instrument such as a DBS electrode equal to the radius of the semicircular arc and inserted at the right angle to the arc will end up in the target point regardless of point of entry. The next step is the implantation of the electrode. We can in this video of a man with hereditary tremor see how this procedure can be performed with the patient awake.
De spänner ju fast den, eller stabiliserar den i öronen, skruvar om in 2 skruvar. Och så börjar skruva åt kronan ordentligt då, och det var en spännande känsla, om man säger så, i hela huvudet. Patrik, läkaren, kom in och då han började berätta just exakt i detalj vad som nu kommer hända och allting, så jag lyssnade där och kände så ja, jo, det här ska nog gå bra. En sköterska fick stå och hålla fast huvudet på mig. och medan Patrik stod och borrade och tryckte ner den där borren. Så det var ju liksom som man fick spjärna emot lite med nacken.
Och det är en lite ovanlig situation.
Ja, det är inte varje dag någon står och borrar hål i huvudet.
Nej.
Sen dricker jag jävligt mycket mjölk också.
Ja. Och håll handen rakt ut. Okej.
Jag håller.
Ja, och peka på näsan. Bra. Då är elektroden på plats. Inte så illa utan ström då.
Allvarligt.
Ja.
So, let's look at this again. We can here see the introduction of the lead. And here we can follow the track for the brain on video. This is not part of the standard procedure, but only done for pedagogic reasons. And here we see the lead on an X-ray. If the patient is awake, then the effect can be tested directly during surgery. You see that the patient is shaking in his hand. I have introduced the electrode and increased the current, and now he's shaking only in the finger. I increase it a little bit more, and most of it is gone, so I increase it a little bit further, and now it is completely gone. Another way of evaluating if the lead is in a good place is by using microelectrode recording, or MER, where you look at the activity of the neurons in your target to see if this activity is in accordance with what you would expect. However, in psychiatric disorders, the information gained from such investigations is often limited, and most centers will perform the surgery with the patients asleep and rely instead on an intraoperative X-ray investigation for confirmation that the electrode has ended up where intended. After the electrode has been implanted, it is connected to an extension cable, which is cannulated under the skin down to the chest, where it is inserted into a neuropacemaker implanted in a pocket under the skin. Most patients will recover fast and feel well within hours, and be mostly recovered from the procedure the day after. Normally, we will keep the patient for a few days after surgery. And if anyone would like to see the whole procedure in detail, then you will find the lecture Implanting a DBS System at the Stereotactic Academy. There are many variations in how DBS is done around the world, due to different traditions, the team's experience, reimbursement, and other factors. Some of the most important being asleep or awake, as we have already discussed. The length of the procedure varies considerably. I will myself typically perform a bilateral implantation, including connection cables and IPG, in about 1.5 hours from skin to skin. But in some places, the tradition is to use extensive intraoperative testing, which might result in longer procedures. In some countries, the procedure is divided into several operations performed at different days, stretching sometimes over several months. There are also variations in surgical details, such as if a stereotactic frame or another device is used, and where the neuropacemaker is placed. Instead of the chest, it is often placed at the belly, or sometimes in the armpit, or even in the buttocks. The imaging can be done in various ways, and not everyone will verify after surgery that the electrodes have ended up where intended. The postoperative stay might vary, and some will discharge the patient to their home already on the day after surgery. DBS is a technically advanced procedure, but it can be seen as a small procedure, albeit in a highly sensitive organ. And DBS is in experienced hands associated with few complications of a serious nature. However, it is important to be aware of these risks, since DBS is not done in order to save lives, but in order to improve the quality of life in our patients. There are quite large variations in the reported rate of complications following DBS, and this is perhaps not surprising considering differences in experience and the many variations in how the procedure is done. I will here follow this detailed review of 2,200 patients and also mention my own experience. But to get a good appreciation of the risks, this should be discussed by the patient with the individual DBS center. Complications from the implants themselves, such as cable breakage, straining cables and malfunctioning, occur in about 2% according to the literature. Such side effects will not be life-threatening, but often minor surgery is required to correct them. We are more afraid of infections. These can occur within days after surgery, when you change the battery, or at any time due to unknown causes. They are seldom very dramatic. Most often the patient will notice tenderness, redness, heat and swelling somewhere over the implant, and this might progress until the implant is exposed. In order to deal with this, it is most often necessary to remove some or all of the implants and to treat the patients with the antibiotics for some time before the implants can be replaced. This is seldom a major threat to the life and health of the patient. In the literature, the reported number of infections and erosions is rather high, around 3% each. In my personal experience, 0.7% of our patients have suffered intracerebral hemorrhages, but these have all been small and with modest and always transient symptoms, with full recovery within a short period of time. The frequency of hemorrhages varies considerably in different reports, probably due to differences in experience, patient selections, and surgical techniques, but in the review presented here it was 4%. The number of symptomatic hemorrhages is of course smaller, but they do occur and are in most cases the reason for the few deaths caused by DBS surgery. Sometimes a patient will contact the referring center to discuss suspected complications, and when dealing with suspect infections and erosions, then it is prudent to contact the DBS center immediately in order to save the DBS system if possible. Remember also that DBS malfunction due to battery depletion or other causes might be a medical emergency. Some patients with Parkinson's disease or dystonia might become severely affected if the stimulation is discontinued, and a few might even require intensive care. Patients treated for psychiatric disorders will not need intensive care, but an acute loss of the effect can still affect the patient severely. Other hardware-related problems such as straining cables, etc., are also best left to the DBS center. Suspected stimulation-induced side effects will, in newly implanted patients, be identified and dealt with by the DBS center. But if suspicion arises in a patient after a longer time, it is also best to contact the DBS center. In such cases, the stimulation will be modified or simply turned off to decide if it is really a stimulation-induced side effect. However, it is important to use common sense. We get many odd referrals, like a patient with full-blown pneumonia with high fever who was sent to us from another hospital in an ambulance because of what was called stimulation-induced breathing problems. Most medical problems are not DBS related, and it is best to treat these patients as all other patients, ruling out the most common explanations before considering if the DBS might be the problem. We will, after surgery and before the stimulation is started, identify the location of the electrode contacts. When the electrode is placed in the same manner in all patients, then we can expect a similar response to stimulation. If the electrode is correctly placed, it's often possible to predict the most effective contact reasonably well from its anatomical location, and this information is further of value for understanding the encountered side effects. The stimulation can be started with an external programming device directly when the patient has recovered from surgery, but often the start is delayed, typically with about 4 weeks, to avoid influence from microlesional effects, that is, the edema surrounding the electrode immediately after surgery. The patient is further equipped with a remote control, with which they can control the stimulation, check the battery level, and sometimes make minor adjustments of the stimulation parameters. We can shape the field of stimulation in various ways. The areas in the brain that we want to stimulate in order to reduce various pathological symptoms are not physically isolated entities. They are bordered and entangled in other structures where stimulation will cause unwanted side effects. We thus need to find stimulation settings with a stimulation field that will mainly encompass the intended target area while minimizing the spread outside of this. The most important aspect of stimulation is the location of the field of stimulation, and this is most strongly influenced by where we are letting the current exit the electrode and enter the brain, thus the contacts of the electrode. All electrodes have at least 4 contacts. These are 1.5 mm long and separated by a distance of 0.5 mm in the most frequently used models and by 1.5 mm in other models. And there is even a lead with 8 contacts in a row. Previously, all contacts have been ring-shaped and placed along the axis of the electrode, letting the current pass in all directions. But today we have also directional leads, enabling us to move the field of stimulation away from the axis of the electrode. You can choose to activate one or any number of the available contacts. Adding more active contacts will spread the field of stimulation. Typically, stimulation is started with only one contact, and depending on the target and individual factors, a second contact will sometimes be added, and rarely more than 2. The amplitude is the strength of the electric charge delivered through the electrode. This is measured in volt or ampere. And current is a measure of the flow of electrical charge, the amount of electricity delivered to the tissue. In modern systems, the voltage will adapt to any changes in the impedance, ensuring a constant current and a stable field of stimulation. The current or flow of electrical charge is not constant but delivered in short pulses, and frequency is the number of electrical pulses per second. High-frequency stimulation is used in all common targets. It's typically started at 130 Hz and sometimes increased up to 180. Each pulse has a certain duration, and this is called the pulse width. This is measured in microseconds. Typically, stimulation is started at 60 microseconds and sometimes increased to 90, and in rare cases to 120 or more. The mode of action of DBS can be thought of as using electric current to replace the pathological signals in the neurons causing the various symptoms with nonsense signals. And the size of our field of stimulation varies with the stimulation parameters that we are using, but will often extend about 3 mm from the electrode contact. However, we need to remember that there are no specific centers in the brain for obsessions, depression, anxiety, or other such symptoms, but these symptoms are caused by pathological activity in various networks in the brain. The stimulation field itself from the DBS electrode will affect an area only a few millimeters away from the electrode. But since we are intervening in networks, this will have effects also far away from the electrode in other areas of the brain. At the first programming session, it is common to start with a so-called monopolar review, where each individual contact is screened regarding effects and side effects. Based on this, what is believed to be the optimal stimulation parameters will be chosen. Often the immediate effects and side effects of stimulation are rather discrete in psychiatric DBS. Just to give an example from my own experience of BNST DBS for OCD, we will on the deepest contact often see increased anxiety. On the second and third deepest, the patient will often look more relaxed and start to talk more, even if they don't notice any difference. On the fourth deepest, we seldom see any acute effects at all. The information gained from the survey is of limited importance, and the contacts can be chosen mainly based on their anatomical location. We have tried various settings, but we have ended up with the 2 middle contacts in virtually all patients. The first programming session is just a start, and it's necessary to optimize the stimulation parameters over time. How this is done varies much between different indications, targets and teams. My own team will optimize the stimulation again after 3, 6 and 12 months, or more often if necessary, but other teams will be more active. Most patients will have entered a stable phase regarding the stimulation within 18 months, and after that changes of the stimulation settings are more rarely done. We can choose between rechargeable and non-rechargeable neuropacemakers, and these have different advantages and disadvantages more or less suited to the individual patient. A rechargeable battery will last for 15 to 25 years, depending on which brand is used, and a non-rechargeable for about 3 to 4 years. This is, however, very dependent on the energy consumption in the individual patient. In psychiatric DBS, the energy consumption is often high, and a rechargeable IPG is often but not always preferred. DBS is done in order to improve the quality of life of the patient. And after surgery, the idea is that they should be able to forget that they have undergone this procedure. The implants will not break or change position if they fall or suffer a minor trauma, and they can virtually do whatever they want without taking the DBS into consideration. However, the implants can be affected by external forces, which we need to take into account when performing cardioversion, diathermia, MRI and such. With modern implants, MRI can be done, but it's important to know which implants the patient has and to follow the specific protocols. When questions arises, it is best to contact the responsible DBS center. DBS for psychiatric disorders is still unusual, but DBS is today with about 230,000 implanted patients an established treatment for Parkinson's disease, essential tremor and dystonia. So, just to see how this treatment is commonly used, let us have a brief look at these conditions. Here we have an example of Parkinson's disease, and we can see the effect on slow movements. In these patients, DBS will reduce the symptoms with about 50%. We see also that this patient has some tremor in the right side, and the best effect of DBS is actually seen on tremor. And DBS is used for many different forms of tremor besides Parkinson's disease, the most common being essential tremor. Essential tremor is a common condition affecting about 0.5% of the population. These patients are often severely handicapped by their tremor, with difficulties eating, drinking, writing and so on. And we are typically reducing the symptoms with about 85% with the DBS. The third major indication is dystonia, which can appear in many different forms. Here in this video we have a generalized form of torsion dystonia affecting the whole body. This patient was before surgery moving constantly, as you see. He had a poor gait and very poor fine motor skills. We see in the video after DBS that he has no involuntary movements. His gait is much improved, and we will soon see that his fine motor skills are excellent. And with that we end the first part of this course, and will now move on to the prehistory of psychosurgery in the next lecture. Thank you for your attention.